IU Matters, Addiction is a co-production of Indiana University Office of the Vice Provost for Research, Indiana University Media School, and WTIU.
Next on IU Matters, it's a public health crisis with devastating consequences, opioid addiction. Now, Indiana University has set its sights on battling the epidemic. Hoosiers are now more likely to die from a drug overdose than a car crash. How will a new $50 million IU plan deal with addiction? Answers on confronting the crisis next on IU Matters. Hello, welcome to IU Matters. I'm Anne Ryder. Today we give you a look inside the effort to combat one of the biggest problems facing Indiana and the rest of the country. Opioid addiction. It's wreaking havoc on Hoosier communities. Now, Indiana University has announced a $50 million initiative to fight the epidemic. In a moment, we will talk with this very distinguished panel of research leaders who will focus on the wide array of issues that have gotten us to this point. And we'll talk about the effort to turn this crisis around. First, though, a look at the combined effort to find solutions to the opioid crisis here in Indiana. Here's reporter Juan Alvarado.
Indiana is one out of 4 U.S. states where the fatal drug overdose rate has quadrupled since 1999.
This crisis affects everyone, all socioeconomic levels, all races, all backgrounds.
One Hoosier is sent to the hospital for an opioid overdose every 2.5 hours. That crisis is what brought Indiana Governor Eric Holcomb and IU President Michael McRobbie together at the Indiana State House. McRobbie announced Indiana University will join the state's battle against drugs by starting a $50 million Grand Challenges program to find solutions for the issue.
We will work to address key issues in substance abuse prevention, early intervention, treatment, recovery, and enforcement.
IU plans on hiring 10 faculty members, increasing the number of researchers, and using student work to seek for strategies to accomplish the goals. People gathered for the announcement watched a video that told the story of Nick and Jack Savage, two Indiana brothers who passed away after experimenting with opioids.
Nick and Jack were 18 months apart.
Their mother, Becky, has turned into an activist.
I still can't believe that they would make choices that they did that night. This can happen to anybody. No families are untouchable.
IU's nursing school dean, Robin Newhouse, will be leading the research into how addictions take hold and take lives.
Together, we will develop a deeper understanding of the neurobiological, social, behavioral mechanisms that underlie addiction and pain response to addiction in community context.
Where there's hope, there's a chance to save lives.
For IU Matters, I'm Juan Alvarado.
Now to our guests. With us today are faculty members involved in this massive research effort. Robin Newhouse is the steering committee chair for the IU Grand Challenge on Addictions. Peter Emby is an internationally recognized expert in biomedical informatics and is president and CEO of the Regan Street Institute. Kosely Simon is a nationally known health economist specializing in applying economic analysis involving healthcare policy. And Ken Mackey is the director of the Gill Center for Molecular Science at Indiana University. He oversees vast new research in brain function. Thank you, all of you, for joining us. So, Dr. Newhouse, let me start with you as team leader of the Grand Challenge. Grand Challenge, indeed. I mean, this has escalated. So what is the biggest challenge facing us right now?
Well, the biggest challenge is addressing addictions and decreasing the substance use disorders, the number of people that die as a result of opioid overdose, as well as the number of children, babies born with neonatal abstinence syndrome. That's the major harm that we're addressing. And this is an unprecedented effort, really, that is focusing on our best capacity, but not IU alone. It really is, this is a partnership, and it's a partnership with the governor and the state. It's a partnership with IU Health and Eskenazi and others. Many of the research teams have a number of other partnerships as well. So this comprehensive response is based on a need for a very complex, complicated illness. And there's not one solution. There's not a single research team that can really tackle this alone. These are really together goals. And these together goals will address some major areas that we have the highest capacity to respond to. As an academic setting, we have high capacity to educate, to provide more certification programs, to get more addiction specialists out. And that's just not one kind of clinician. We have 8 actually health sciences schools that will be involved in this education, as well as a number of the non-health science schools. There are teachers in the community, for example. It's every one of us that needs some additional education to recognize a problem and to be able to get people to the help that they need.
So again, it's bringing everybody together. To that end, Peter Envy, you're kind of the big data guy. Why is it so important to have big data in trying to reduce this problem?
Well, we know that understanding the problem really relies on having the data and the information, pulling that all together to be able to better characterize the extent of the problem, where the problems are happening, know where we need to mobilize resources to be able to address the crisis. And so we have actually in Indiana a vast array of information resources that we can pull on, but historically they haven't been as integrated as they could be in a way that is motivated by a real need like this. So one of the opportunities here, I think, is to take the vast amounts of information we have, for instance, in healthcare data at places like the Regenstrief Institute, social and behavioral information that we have across IU, places like the Polis Center, our government resources through the Management Performance Hub, through the state, a lot of which are really leading data sources that, if only we could bring them together in the right way, could much better enable the kind of research that we need to do, the kind of interventions that we need to take, and both in the short and long term, better position us to be able to know where is the crisis happening now, where is it going to happen tomorrow, how do we address it, and how do we really solve the problem?
Well, you said Indiana in some respects is, we have more data than many of the states. It's just a matter of coordinating all of that.
That's right.
To get to the answer. Ken, I know you do study in the brain and that kind of thing. This may be, the big question that you can't answer quickly, but how does it get from a painkiller, casual use, to addiction so fast in so many people?
It's a hard question to answer, and basically what we need is more research to look into that. We know that the body's very good at having one protein and one receptor used for many purposes, and that's the case for the mu-opioid receptor, which mediates both the pain-relieving effects of opioids, such as fentanyl, heroin, etc., as well as mediating euphoric effects. So the body's very conservative that way, that there's this unfortunate duality that receptors that relieve pain, or some types of pain, also produce euphoria and addiction.
And as we move along, I know you're doing a lot of work into the receptors that we already have in the brain, where we could potentially get pain medications that are not opioids.
That's a
correct?
goal. That's
a goal
for all of us.
Yeah. Kosali, you're on the insurance piece of that. Help us understand how that works and why that's important.
So insurance is an important mediator here in many ways. First and foremost, let's think about treatment as being a really essential part of fighting this addiction crisis. So to the extent that insurance is paying for and that treatment is available, that's a really important stage we should think about. Insurance also can serve in other ways to think about where the problems start and think of the role of over-prescribing being the way that we got into this situation. So if payers, in addition to healthcare systems, step up efforts to control the inappropriate prescribing while leaving the appropriate prescribing unharmed, then that also is a way that insurers and payers can take part in fighting the crisis.
So much of what we're learning ties right into this next story. Columbus, Indiana native Jim Ryder got hooked on painkillers at the age of 17. Ryder was born with spina bifida, so pain was a way of life for him. He had a promising music career in his 20s. He played on John Mellencamp albums, had his own hit song and record deal, and appeared live at Farm Aid in 1993. But his addiction to opioids took over his life until he got clean 18 years ago. The wake-up call was something John Mellencamp said to him. Now, Ryder is the director of chronic pain and chemical dependency programs for IU Health. His past and his understanding of what he calls addict logic helps him to connect to addicts trying to quit.
I remember fear, and I remember all the things from surgery, but I don't remember physical pain until I was probably about 17. I had surgery when I was 17. I had really bad kidney problems, and kidney pain is pretty awful, and so they gave me Percocet for that. And I took them one day for a headache, and it was just like, bam. And then I started writing music with it, and it kind of opened up my world, if you will, and ultimately became my world. Believe it or not, there were many different turning points. You know, I knew I had a problem, didn't know I had a problem, but I knew I didn't like the way I was living. And kind of the standard joke around the house was, Jim's a perkaholic, you know, that kind of thing. And so, and I became moody, and I kind of noticed some of my downfall. Eventually, I was prescribed IV Demerol while I was at IU. I mean, I would shoot up in class, take an exam, go home, sleep, shoot up again, and and I remember one time I'm sitting there shooting, and I'm like, I wonder if junkies feel like this. I'd gotten to a point where I was so frustrated and so upset. I was like, I'm done. I'm going to end this. And I pulled up a lethal dose. I don't know if it would have killed me now that I know about tolerance. And I looked at my stupid little chihuahua sitting right in front of me thinking, who's going to take care of her if I do this? And that was enough to make me stop that day. And then it was an encounter with John. We were water skiing at his place. John just looked at me, he goes, man, you're a junkie, dude. You're gonna have your pills and you're gonna have a beer and you'll be just fine. I don't think he had any idea of how good that ultimate truth was for me, but he held up a mirror and said, how do you like what you see? The thing that I appreciate about the Grand Challenge is that we're really looking at this illness holistically. One thing that's very important to me in this field, and as the director for pain and addiction, is that we don't get lost in just opioids, that we continue to focus on all drugs of abuse. The thing that I also appreciate about it is that we're all going to be working much more closely together, because we've been siloed for years. Mental health, physical health, this health, that health, and kind of bringing it all together, I think, is going to be really important.
So Ryder has been counseling other addicts for 15 years, and he's been clean for 18 years. In fact, I asked him, I said, have you relapsed? He said, I relapse every day, I just don't act on it. So an addict is an addict. Robin, when did this come onto your radar screen in terms of the scope of our problem?
Yes, well, we've had it for a long time. I've been a nurse for a long time and have seen it in the clinical arena and the effects, but it's actually become far more known today and far more devastating, both in terms of health, chaos in families, and death. So we're really sitting up and taking notice at this point. And I think that the other thing that we realize is that we're all aware of it in our communities, in our families, in the faith community. So it's something we can no longer ignore.
Well, let's talk about that. I mean, this affects everything from newborn babies whose moms were addicted, to the elderly, to almost everybody in between. Who would like to address that?
Yeah, certainly I can start. I think as a physician as well, who also treats pain as a rheumatologist, that you're right. It's something that affects all of us. At any point in time, everybody experiences pain, and to the extent that we would like to decrease that pain, we look to our healthcare community for help with that. And for a long time, one of the major tools we've had in our treatment arsenal has been opioids. And the pendulum has swung over the years in terms of how to use them and how to treat them, treat patients with pain. And of course, we have to do that, and it's the right thing to do. The issue is that how we do that often isn't as sophisticated as it needs to be. It doesn't always lead to the best possible outcome. Some people take pain medication, get over whatever they're dealing with, and move right on with their lives, and others unfortunately become addicted. So better understanding what the source of that is, why that's happening, and how to address it so that we don't allow people to suffer with pain, but at the same time, we don't create a new problem.
Well, Ken, that's kind of your area, is the brain in all of this. What's our takeaway here?
One is just follow up on what Peter said, that there is a pendulum in terms of healthcare going from under-treating pain to over-treating pain. And there's been an issue, of course, with the easy availability of prescription opioids and some of that is driven by a number of factors, both emphasis from drug companies for physicians to prescribe those, as well as a lot of expectations on the patient side, take a pill, feel better, and pain, as all of us who've either experienced pain or treated pain know, is much more complex in that different people respond very differently to their pain, how they sense the pain, how it affects their lives, and also what treatments they respond to. One thing that we're very interested in on the basic science side of our research is developing new strategies to treat pain, whether that's pharmacological or behavioral. And I think that's an area of very intense research.
It's very interesting. We'll circle back around to that. But in that video, Kosali, we saw, some of the addicts took to crushing the pills, especially OxyContin, and then they reformulated OxyContin, correct? Can you speak to that?
Yes, so we have to always be thinking ahead to whatever the next regulation is, how might people react? And this is where economics, and particularly behavioral economics, really helps frame the thinking around how might human beings respond when one form of availability of prescription drugs is reduced. You have to keep in mind all the alternatives that might then be the sources that people turn to. And that was really a lesson learned in the pharmaceutical industry from efforts. You think the easiest thing to do when you see prescription drugs being abused is that you would change the technology of that particular drug. But you have to keep an eye on all the other ways that might not work as you expected. So I think looking ahead to unintended consequences, monitoring and figuring out solutions that really solve the problem rather than one aspect of it is important.
Why did it just take off, though? I mean, we've had painkillers around for a long time. What are some of the factors in it just becoming exponential? Not just nationally, but here in Indiana, we're what, 11th most addicted state?
Well,
is that right?
Certainly 11th in, you're going to have to take
Oh, well, that's no, I threw you a curveball there. That is mine. Okay. I just know it's a serious
11th
problem.
Out of 50 in opioid prescriptions.
Yeah.
Yes.
So what happened here? I mean, we hear about fentanyl, we hear about, abuse of all kinds of things that were never meant to be abused. But what went wrong?
We hit the tipping point, and we've known about it for a long time. The Joint Commission over a decade ago said about a third of the patients admitted to acute care hospitals actually had some risky alcohol use, and started to promote metrics related to quality in hospitals. So we did a study just trying to figure out how best to get screening, brief intervention, referral for treatment, and that is known as a good process to identify people, to do a brief intervention and send the message, and also find a place to refer them to treatment. So that was a decade ago, and there is plenty of evidence that should be implemented, but it's not. But now we're seeing the chaos in families, the death of people, no matter who they are, where they live, within families, and in our communities. There's not a family that's not touched by this. So we have hit the tipping point where we not only realize that it's affecting the health of Hoosiers, it's the children are dying. They are born with addiction on their first day of life and drawing breath. And we just can't ignore this any longer.
Yeah, I think that's right. I think the information tells us that the coordination of this care is another big part of it. So, we see people who at some point require this pain medication, and then they'll either stop getting it from their particular provider, go look for it somewhere else. We have technologies and we have abilities to be able to track where people are getting the information. It doesn't always make its way to the right person to make the right decision, and so there have been interventions to say, how do we use information and data to help us better understand that, help people get the right kind of treatment they need. But that hasn't always been very well coordinated, and it's been challenging. And I think increasingly, through the work of basic scientists and others, we've started to understand too that certain people are predisposed to becoming addicted. So the more we can bring information about each of us as individuals to the table in terms of what is our genetic predisposition to this, what is our societal sort of expectation, and the home life, the behavioral elements, The more we have a better understanding of all of that through bringing our different information sources together, and then importantly can get the right information to the right people at the right time to either make good treatment decisions, good policy decisions, et cetera, we begin to start to understand how we can tackle this issue. And I think we're heading in that direction. The challenge is going to help us do that.
Quick question regarding insurance. So when people go around in doctor shop and try to get, a prescription over here and a prescription for opiates over here, shouldn't that ring some bells with the insurance companies?
Yes, and also with the prescribers themselves. So a state policy that has shown really great promise is having prescription drug monitoring laws that require prescribers, healthcare providers to enter into a system all the information of who is getting what and have that be available real time. Now, a challenge comes up, which is how does that get integrated into electronic health records? How is it going to be something that physicians can check very easily without having to go through multiple logins? So there's still a long way to go, but we do know that providing information, making sure that people know when they're making decisions what else a patient has is going to be vital.
But the answer to those questions, that's kind of what Grand Challenge is about, connecting all those dots. Let's go back to the brain for a second, because you were talking earlier about receptors that we have. How can we use those receptors to do the kind of research which you're doing to find new pain remedies?
Yeah, I guess one thing focusing on the receptors is, of course, a big issue with opioids and overdose is tolerance. People become tolerant to the euphoric effects of opiates, so they take more and more to get the desired high. Unfortunately, tolerance to the respiratory depression effects of opiates doesn't increase at the same rate, so that receptor imbalance is a major driver of essentially death in opiate overdose. So one area of research is actually trying to understand the processes underlying tolerance. Another, to get back to your question, general effect is what other receptor systems in the brain, and we have many, many different receptors in the brain, can we utilize to relieve pain, particularly chronic pain. Opioids are extremely good for acute pain if you break your leg or something like that. They're not so good for most patients for chronic pain, chronic back pain. They may mask some of the depressive effects of chronic pain, some of the higher level psychiatric effects, but they don't usually treat the basic problem that's causing the chronic pain.
So how can we do better?
That research is to understand, and this is actually perhaps a good, I don't know if this I use intention or not, but a good integration between another grand challenge, the personalized healthcare grand challenge, and the addictions grand challenge, because for many people, there's not a one-size-fits-all, whether it's for treatment of opioid abuse or treatment of chronic pain. Is better research understanding, can we predict who will respond to treatment A versus treatment B for chronic pain? And that starts with basic science research in their preclinical models and moves to applied research with patients to try to figure that out.
Quickly, to talk about some of the research that you're doing with, and help me here,
Okay.
It's not cannabis, it's...
So specifically, my lab's interested in cannabinoids. So cannabinoids include THC and cannabidiol from cannabis plant, as well as our body makes endogenous cannabinoids, so the parallel between morphine and endorphins, THC, endogenous cannabinoids. And that system has a role in treating pain, some types of pain in some types of patients. There's pretty good evidence for that. And there are different ways of harnessing that system, whether it's activating the receptors with something as simple as medical marijuana, or if it's harnessing our endogenous cannabinoids and boosting their signaling, boosting their pain relieving.
But it's not something that will make people high. So it's not like thinking about smoking pot.
Right. Medical marijuana can make you high depending how you use it.
Right.
But the systems that we're looking at don't make you high.
Yeah.
The drugs.
You know, it's interesting. You're talking about the addict logic. Jim Reiser told me that if an addict hears somebody died, that they know their first thought will be, oh, I need to get some of that. Thinking that, well, you know, they built up such a tolerance, they think, oh, well, that's going to give me my next big high. Because doesn't it get to the point, they say, where you just need the opioid to feel normal? Is that correct?
Yes, more important than air.
Yeah.
More important than and getting off of it, it can be brutal.
And fortunately, it's pain. And so, as you become more used to getting these pain receptors fulfilled with the exogenous opioid, then, to the extent that you don't have them, your body basically senses that as pain, physical pain, psychic pain, and it's awful. And in fact, it's part of the problem. But I think this, as Jim also said, I think the idea that we need to address this in a more holistic way, right, with bringing all of these different silos of information and service and healthcare together. We do have some fantastic examples historically here in Indiana. It's actually, we're pretty well advanced compared to a lot of other states, so I think we have a bit of a head start to really capitalize on this challenge, because the degree to which we've brought together a lot of different elements, and we've actually done some projects historically with the likes of the Centers for Disease Control and others to say, how do we bring, as Kosely was saying, how do we bring that information to the providers so that they can better take care of their patients, really understand what's happening. I think we have a good opportunity to overcome a lot of that and really make some good advances to help address this more holistically.
This has gone way too fast. Way too fast. This is such a big and complex issue, but thank you, all of you, for being here. So it is time to wrap up our IU Matters Roundtable, but this initiative to fight opioid addiction is just beginning. Again, thanks to our guests, Robin Newhouse, Peter Emby, Ken Mackey, and Kosely Simon. We appreciate so much the work that you all are doing. And thank you for joining us. For all of us behind the scenes, I'm Anne Ryder. We'll see you next time on IU Matters.
IU Matters, Addiction is a co-production of Indiana University Office of the Vice Provost for Research, Indiana University Media School, and WTIU